All right, Dr. Bradley, I think we're ready to begin.
All right, thank you. We will go ahead and call to order this morning at 9:02. I will turn it over to Shelley for roll call.
Thank you. Andrew Tang. Anthony Griffey.
Here.
Brent Burgett.
Present online.
Brian Stevens.
Good morning, I'm present.
Who? Chris DeChamp. Cliff Jones. David Natrika.
Present.
Debbie Johnston.
Present.
Edgar Bissonette. Franco Castro Marin.
Present.
Gail Bradley.
Present.
George Gamer.
Present.
Herman Butler. Ayman Pfizer-Fan. Judy Baum.
Present.
Melissa Anderson.
Present.
Nirav Patel.
Present.
Rod Reed.
Present.
Dan Nygaard. Sean Bowker.
Present.
Tara Johnson. And Vicki Bennett.
Present. Shelley, this is Sandy. I'm here.
I count 16. We have quorum.
All right, thank you very much, Shelley. I appreciate it. All right, good morning, everyone. Thank you for those of you that are here in person with us today. So a couple of housekeeping items. We do have the attendance report in your packet. Just a reminder that if you do miss 2 or more meetings in a row, we will contact you to see if you still would like to participate on the committee. We do have a couple vacancies. We have 1 vacancy from a rural advanced life support-based hospital that is not a trauma center. And we also have a vacancy for representative from a statewide rehab facility. That one is effective at the end of this month, the end of January. If you qualify or are interested in either of those positions, please send your CV and letter of interest to Shelley Bissell. I also wanted to take a moment just to thank a couple of longtime members of this committee that are no longer serving. First is to thank you to Judy Baum. She was a longtime member of this committee who has resigned, and also to Dr. Philip Johnson, who also was a longtime member of this committee. So thank you to both of them. Next, I just want to a quick update regarding the FR Care Grant Award. So we are kind of publicizing this at each one of these meetings, but we just wanted to make sure we share this information again in this format. The Bureau was awarded another 4-year grant as part of the FR Care program. We had another meeting yesterday and getting ready within the next couple months to really start going live statewide with really getting this program up and running. There are some entities that have already instituted the naloxone leaving high program, but we really want to see more EMS agencies participate in this process. So as we move forward, you will get quite a bit of communication, but we did want to mention that will be coming forward. Next on the agenda, we're going to go a little bit out of order, if you don't mind. I know we had a presentation from Melissa Luston. We do need to have Chief Garcia give her report first, and then we will move back to the agenda. So I will turn it over to Chief Garcia.
And good morning, all. It is so good to see so many of you in person today, and I hope the audio is okay and you can hear us online as well. Happy New Year. Happy 2023. Sorry for going out of order, but I have to tell the folks in the room I do have to get up and step out of the room for just a moment, and then I will be right back. So had to jump in order, and thank you, Melissa, and everyone who is giving a presentation today. It looks like a good agenda. We are, as you all know, heading into legislative session. It kicked off in the last week, and for anybody that has not heard, the governor has appointed a new ADHS director who is beginning to transition into her role officially here at the state. She will be here officially by the end of February, but is engaging with state leadership now, and we're really looking forward to working with Dr. Teresa Cohen from Southern Arizona. She's going to be a great addition and leader to the team. For those of you that have not had the opportunity to meet her yet, for legislative session this year, the department is not sponsoring any bills this year, but we are, of course, staying engaged in legislative session. And if anyone has any questions about anything that impacts trauma or EMS this session, we are always available for questions. Please reach out if you have any questions for the Bureau of EMS and Trauma. We will remain available to you all throughout legislative session. On the rules side, the department is working on several rule updates. We want to make sure we continue to keep everyone informed through these meetings. We are required by statute to do a rule review every 5 years on our administrative code. And so right now we are looking at ground ambulance rules. We are looking at EMCT certification and training, and we are also looking at trauma rules, because those are the rule sets that have not been reviewed in 5 years. We, as you all know, continue rulemaking related to ground ambulance, and we are also seeking approval to update rules for both EMCT certification and training, as well as trauma rules. If we get approval to update those rule sets, it would be in a limited capacity. We would only be able to follow what is outlined in statute, and we have to stick to the statutory requirements when it comes to these updates. For trauma rules, if we do get approval, we would expect that it would be very minor updates that would just allow us to clarify some of the time frames for trauma designation. And of course, as a next step, if and when we get approval, we will make sure that any drafts that are posted, we keep all the stakeholders informed and let you know when there's an opportunity for public comment. But at this point, we would expect a very limited opening and update to any rule sets. We'll keep you all informed as we move forward. Next up, we want to make sure, I think it's on the agenda a little bit later, but we want to plug two things. We're looking for feedback from stakeholders in a needs assessment survey that will be going out to all of our trauma and EMS providers. More to come on that. That's going to be a big push for us this year. We also are going to be launching a new trauma and EMS portal. So we will be highlighting that a little bit later in our agendas today. And we just want to tell you, we really look forward to previewing those things, and definitely look forward to questions. I think that is all I will wrap up for now, but I would like to introduce new staff really quickly. We have in the room at least 3 of you, right? Tell me if we're forgetting anybody, but to my right, yes, you're going to be new for at least another quarter, just so you guys know. We have Brian Hubble, our new CON and rates manager. Thank you for joining us, Brian. We have Jeff Kerr, our new compliance manager. Thank you, Jeff. And Sebastian in the back, he joins us working on our first responders opioid grant at Cara. So thank you again, guys. We're looking forward to working with you and you all getting to know them as well. Carissa, if you can hear us, we'll turn it over to you really quickly for a State Trauma Registry Trauma 1 update. Can you hear us?
Yep, I can hear you. Yeah, so hi everyone. I don't have any major updates. We just wanted to keep you in the loop. I've spoken with ESO and they are still kind of working on their new registry product. It's been pushed back a bit, so we don't anticipate any changes this year. We're going to go ahead and wait until they have their new product ready, and we're going to keep looking at our options and just wait until they're a little bit further along. So when we get any new info, we will share it with you guys.
Thank you, Carissa. All right, we will go back to our presentation. Is Melissa Luxton on the line?
Good morning.
Good morning. Do you have anything you'd like us, Shelley, to present for you?
Yeah, am I able to just screen share?
Yes.
Let me get it up really quick. All right, can everybody see that okay?
Yes, we can. Thank you.
Okay, great. So my name is Melissa Luxton. I am the chairperson for the Arizona Falls Prevention Coalition, and I'm also the Trauma Outreach and Injury Prevention Coordinator at Banner University Medical Center, Phoenix. And this morning's presentation is going to be on the topic of strengthening falls prevention efforts with the help of first responders. So I presented this about a month and a half ago at an AIMS meeting, and there was a lot of piqued interest. So I was invited here this morning to present again, and I hope you find it all interesting. Some of the information may not be shocking, a little bit of it may be shocking to you, and then just maybe a call to action on what we could potentially do in our state to strengthen these efforts in our community. So just really quick, going to highlight over the objectives from the presentation. So I'm going to discuss the prevalence of falls in the state of Arizona, the importance of falls prevention education, the impact of those prevention efforts with the help of our first responders. I'm going to brief over the statewide impact of what the coalition does, and then how partnerships through the continuum of care strengthen those prevention efforts. The burden of falls. So everybody in the room, I'm sure, knows that falls are very common. The consequences can be serious, as we've all seen. And as far as unintentional injuries goes, falls are the 7th leading cause of death among older adults. They're the #1 cause of unintentional injury deaths among old adults. But overall, when you're comparing it to cancer, heart attacks, strokes, things like that, it's number 7. So it's still pretty high up there. And this statistic has been one that's ran for years and years and years, that 1 in 4 older adults will fall this year. And that's widely underreported because that's only the ones that are reported. Our leading causes of death, again, you can see that unintentional injury is number 7, fall being the #1 reason. Every second counts in those older adult falls. So every year, 36 million falls, 8 million injuries, 3 million ED visits, and 32,000 deaths. And that is nationwide. As we all know, those consequences of the fall can be serious. So among those common causes are hip fractures and traumatic brain injury. More than 95% of hip fractures in older adults are due to fall, and they do have a high 1-year mortality rate. They often lead to loss of independence, such as like assisted care living or nursing home placement. So a big change in the quality of life in our older adult patients. And our fall deaths, the rates are on the rise even after adjusting for that aging population. So every year they keep going up higher and higher. They're super costly, which is, again, probably no surprise to anybody. $29 billion a year spent through Medicare, $9 billion spent through Medicaid, and $12 billion private out of pocket. So they cost us over $50 billion every year. Touching on our statewide statistics, so Arizona, this graph here shows Arizonans 65 years of age with a fall resulting in death, hospitalization, or ED visit. And you can see that it has been on the rise since 2016. 2017, we didn't have any reporting data, but you can see it continues to rise. It did fall over 2020, I think, possibly due to COVID and people kind of just staying home, but it didn't fall too short, still staying in the same range. County-wise, you can see here our accrued mortality rates for unintentional falls among those 65 years of age. This is from 2014 to 2018, and then age adjusted in 2019. And then breaking it down demographically, overall, American Indians have the highest rate of falls-related mortality among all ages. And then the highest rate of falls mortality was 85-year-old males and females. So the more we age, the more susceptible we are for mortality related to falls. If any of you are familiar, I'm sure those of you with AZDHS are very familiar, but I really enjoy the fact that they're doing this new dashboard. It's the 911 call volume, and it goes by region and incident. I'm happy to share the link outside of the PowerPoint. Also, I'm happy to share the PowerPoint with anybody that would like it. But you can go to this website through AZDHS, this link here, and I just threw a screenshot up of what that 911 call volume dashboard looks like. So every week it updates and it tells what the volume calls were, and then it breaks it down at the bottom for the full call volume. And as you can see, falls tops every single other thing versus cardiac arrest, STEMI, stroke, MVCs. In fact, last week, 61.8% of 911 calls were related to falls. That number is so shocking. Even being in injury prevention, once this dashboard launched, I could not believe the amount of fall calls, and they go up every single week. I don't think I've seen a week over or under 1,000. And when you look at the numbers overall for the reported cases on the Arizona State Trauma Registry, falls make up 47.63% of all trauma cases statewide. I'll click on this link really quick just so I can share the dashboard with you. Can you guys all see my web browser?
Yes, we
Yeah.
can, Melissa.
Okay, thanks. So just clicking on the link, the overall 911 call volume, and it's really interactive. You can go by region, so you can search central, northern, southeast, western, and then you can go up to the top where it's got all of them broken down by race, ethnicity. Really interesting if you're in the outreach, injury prevention realm, trauma program managers, or anybody else that would have interest in it. You can go specifically to falls, and then there's all kinds of state registry data on our falls overall. So just kind of a quick, brief overview. It gives you the cost breakdown of what they cost us as a system. I thought this was interesting, where there's alcohol drug use at the time of injury, not something we typically think about in our older adults, but actually 15.3%. So again, I'll throw the link in the chat box in case anybody's interested in exploring that further. I think it's a great addition. Our risk factors for falls, they include our neurological conditions, including stroke, Parkinson's disease, and dementia. Depression, a lot of times, can be a risk factor for falls, especially when we get into the realm of those psychological medications. Arthritis, cardiac conditions such as arrhythmia, diabetes, urinary incontinence. And then our modifiable risk factors, so difficulty with gait and balance, lower extremity weakness, polypharmacy, which is huge, vitamin D deficiency, even in our sunny state of Arizona, most of our older adults and most of us walking around are still vitamin D deficient, orthostatic hypotension, visual impairment, foot issues or improper footwear, and home hazards. So when we talk about polypharmacy and medications linked to falls, one of the things that I recommend when I do education with our fire departments is to review those medications with all patients 65 and older. Medication management can really reduce those interactions and the side effects that may lead to falls. So some of our meds that are on high alert are anticonvulsants, antidepressants, antipsychotics, our benzos, our opioids, sedatives, and then reviewing those prescription drugs and over-the-counter medications and herbal supplements. So things like anticholinergics, antihistamines, blood pressure meds, muscle relaxants, they're all linked to things like dizziness, sedation, confusion, blurred vision, and orthostatic hypotension. So working bedside for many years in the emergency room and the trauma room, one of the things that I always kind of picked up on was the communication between the healthcare team and the first responders. There wasn't a lot of focus on the med list or what they were taking at home. And that could be a huge problem, especially when our patients are maybe not able to answer those questions, or they're not a very good historian or don't carry a med list with them. And so it's difficult to assess and figure out what their risk of falling is regarding medication management and polypharmacy. So what I encourage our fire department personnel to do is to really, if they've got a medication list or if they've got medications in the home, if they can bring them with them to help us identify those fall risk patients and address those issues of polypharmacy. Many of our patients, they don't get all their meds filled at one pharmacy. They have several different doctors, so that can be a big challenge. In discussing the importance of fall prevention education, as I've stated before, each year millions of people over 65 fall. 1 in 4 fall, but less than half of them are telling their doctor. So falling does double your chances of falling. Again, once you fall, and you're more likely to fall. And most of that is due to the fear of falling alone. Many of these falls don't cause injuries, but 1 in 5 falls does. And so when we talk about our head injuries or hip fractures, that can make a really big difference in their overall quality of life, the ability to live independently. So that fall prevention education in conjunction with fall prevention strategies has been proven effective to reduce falls. And it provides numerous advantages such as improving fall prevention awareness, the perception of fall prevention intervention, and self-efficacy. So how do we strengthen our efforts with our first responders? So EMS lift assist calls are very costly. The other problem with them is that they can divert care away from calls that require attention and transport to care. Our EMS personnel, our firefighters and our EMTs, they play an important role in engaging, educating older adults on services available in the community before and after a fall. They're a trusted source of information. Our community members look to them as that source, and they're trusted. EMS often sees older adults in their home, which is different than our hospital-based healthcare providers. They can provide partners with that valuable information regarding the common cause of falls. So what are they seeing in these homes? What kind of barriers are there in the homes? They are the eyes and ears out into the community. And so being able to share that along with emerging trends and insights into the social and behavioral aspects of the community that our hospital-based personnel don't necessarily see. So increasing that communication and identifying those risks. Our fire and emergency systems are now seeing more older adult fall victims than fire victims. They're often being called to the same houses repeatedly for minor falls. The reliance on the fire service to respond to resident falls presents a unique opportunity for our fire, EMS, and aging services professionals to work together to intervene, educate, and ultimately prevent the next one from happening. So a couple of little fun facts, and I don't know if all of you are aware, but among people age 65 and older, falls accounted for 17% of all 911 calls. More than 1 in 5, so 21% of emergency 911 calls do not respond or do not result in transfer to the hospital. That's a lot. That's a huge number. 21% of attention diverted from calls that maybe needed the assistance prioritized. And nearly half of the lift assist calls result in a second lift assist call within 2 weeks. The utilization of EMS services for fall-related calls has substantial financial consequences to communities and decreases the availability of our EMS to respond to more urgent needs, and that's a huge problem. So recognizing the lack of formal training and infrastructure to support their fall prevention activities, there was a community paramedicine agency in Ohio who established a partnership with a group of healthcare providers and researchers at The Ohio State University, along with its affiliated medical center. The goal of this partnership was to devise and implement a quality improvement initiative that could enhance the community paramedic team's operations, that could consistently help reduce falls and advertible transports to the hospital. So what did they do? They formed a multi-stakeholder learning network. They called it Community Fit, and it was a collaborative to expand and support training for falls prevention strategies for community paramedicine program. So they trained their fire paramedic personnel in home environment evaluations to do fall risks and home modifications, such as grab bar installation and nightlight distribution. They optimized their electronic health record within their hospital systems to combine workflow communication between the 911 scene and community paramedic medicine visits. They gathered and analyzed 911 call records to evaluate system level outcomes. And they invested in partnership growth activities such as going on ride-alongs. So they had hospital personnel come along on 911 ride-alongs and home visits with the community paramedicine program to observe those patient flows, both outside of the hospital and inside of the hospital. So they did it 2 ways. The fire came into the hospital and the hospital personnel went out into the community. I'm going to share a quick TED Talk, and this is Carmen Klotman, who led this initiative. She's absolutely amazing and completely inspiring. It's just under 10 minutes, but it really paints a picture better than I ever could trying to repeat what they did. So I'm going to share that with you right here. And let me know if you guys can hear it. Should have it linked in to be able to stream the sound.
Can you pause that just for a second?
Yeah.
Sorry, if this is 10 minutes, we probably don't have time for the full 10-minute TED Talk. We can certainly share the presentation after the fact with the TED Talk, but we do have quite a few other items on the agenda we need to cover.
Okay, that's not a problem. I can
Thank
I can
you.
send it out in email.
That would be wonderful. Thank you.
Yeah.
If you want to send it to Shelley Bissell, she can make sure this gets to the whole committee.
Yeah, that'd be great. It's a really inspiring. They go through. I'll give you the clip notes. They go through how that was initiated, what kind of things they discovered when they dove through their data, and how they ended up implementing the program. And so overall, what they did was they trained their EMS and fire systems with a grant for community paramedicine programs to install those grab bars. They had training facilities within their departments. So anybody that was signed on to the paramedicine program had professional training on how to install those to make sure they were installed safely, which answers the questions on how you cover that legally, as well as how they were funded for it to be able to provide that initiative throughout their community. So yeah, I will. I'll send that out to Shelley, and then she can share it with the rest of you.
Thank you.
Yeah. So one of the things that the Falls Prevention Coalition did in 2022, a big focus through 2021 and 2022, was working on a state bill called A.R.S. 36-420, which is Senate Bill 1373. This was a collaborative effort through this Attorney General's Health and Safety Committee, the legislation of Senate Bill 1373, which later became Healthcare Facilities Duty of Care, Title 36, Chapter 4. This is something that the coalition is very proud of, and the work that our Policy and Advocacy Committee has done to help bring this bill to light. And basically what the bill says is that it requires all senior care facilities to provide CPR, first aid, and aid to people who have fallen until EMS arrives on the scene. It requires specialized training for staff and has a statewide impact, and is actually a model for the nation. Most states do not have anything in place like this. Arizona is one of the first. So the AFPC was specifically named in the Senate bill and the A.R.S. The healthcare institutions are able to use information and training materials from the department's Arizona Falls Prevention Coalition in developing training programs. So what does that all mean? Any licensed care facility has to provide not only CPR classes, first aid classes, but they also have to provide yearly training on falls prevention. They are no longer allowed to have no-touch policies and leave those people lying there. So it really improves the care for Mr. and Mrs. Smith. They're no longer, are able to be left there and just with no aid rendered. So the Arizona Falls Prevention Coalition has worked in conjunction with the University of Arizona over the year of 2022, and we are proud to say that in Q1 of this year, we will be launching an online interactive falls prevention training that every senior care facility will be able to access free of charge and provide that annual training to all of these facilities on falls prevention and lift assist and falls recovery. So just a little bit about the Falls Prevention Coalition. If you're not familiar with it, it was designed to provide information, advice, helpful hints, and tips to help prevent falls and fall injuries by the elderly in Arizona. Through raising awareness of the issue and providing advice to our older adults, our goal is to lower the occurrence of elderly falls, not only just in Maricopa County, but across our state. It was developed to promote evidence-based fall prevention approaches. So our website has all kinds of links to not only our community events that are available for our members and our professionals to reference. It also talks about nationally recognized evidence-based programming. The coalition provides education and information to help those older adults as well as healthcare professionals on all things fall prevention. I like to call our website a one-stop shop for resourcing, which makes it a lot easier, especially when we're talking about our population ages 65 and older. It was a big void that I noticed when I took the chairperson role, that there was no one-stop shop for falls prevention in our state. Everything was very fragmented and in silos. And so when I took the chairperson position, one of my goals was to unite everybody. That's what a coalition's supposed to do. And so our website wasn't very robust. It didn't have a lot of features to be able to showcase all the things that all these organizations throughout the state were doing in the community. Our statewide impact is that professional and public education awareness. We have previously, prior to COVID, held professional and public symposiums, which we are looking to getting back to in this year of 2023. We have engagements through our fire and medical departments, not only here in Maricopa County, but also statewide. Our health systems, which include Banner Health, Honor Health, Dignity Health, and many others. Our local health departments, including AZDHS and our county health departments. And then our higher education institutions. So we have representation from Arizona State University, University of Arizona, GCU, NAU, and many others. And then our outreach. So we do lots of outreach education, not only collaboratively as a coalition, but also individually, and then report that out through our website as opportunities. So how to get involved? Our website is azstopfalls.org. I'll take you there really quick. It's a lovely website that we built out and launched late 2021. If you go here, this is our main page. If you're interested in becoming a member of the Falls Prevention Coalition, we do meet bi-monthly on the third Thursday of each month. So I actually have a meeting to run here and just at 10 o'clock. That is our bi-monthly meeting. To apply for membership, you can just come to the website, click the membership link, and then that will prompt you to filling out an application, which shoots off to us. We just vet it really quick. And then as long as it's not spam, we'll approve you. But we do have some great links if you're ever looking for education to share. We've got our educational video library. We've got educational handouts, our social media toolkit that can be utilized not only all year long, but especially in the month of September during Falls Prevention Week. We not only have our local chapter here in Maricopa County, we also have our Western, Northern, and Southern chapters. So if you're in those regions, you can click on our chapter pages and that will take you to your local region. The AFPC also has many different breakout committees. So some of our areas of focus are American Indian Partnership. We focus on awards and recognizing those doing great work in the community. Our education committee, who develops all of our education that we share. We do evaluate our own organization to make sure we're fulfilling the needs of our members. Our membership committee, our policy and advocacy committee, which did all that great work on the Senate bill. Our grants committee, and then our PR committee. So we're in the media often with TV and radio interviews, as well as podcasts and things like that. So that is our website. I invite you all to take a look at it. It's also a great spot to get all things Falls statistics. So I have different links listed here if you're interested in looking at any of them. Again, it's just a really great one-stop shop. And at that, I will go ahead and open it up to any questions that anybody has. And my email contact is listed below for anybody that would like to reach out for more information.
Thank you, Melissa. It was a wonderful presentation. If you don't mind sending that to Shelley Bissell, it looks like we've got a couple requests for a copy of that. She will make sure it goes out to the committee. We did share in the chat. Thank you, Melissa, for publicizing our 911 dashboard. That is something that Voxel has really spent quite a bit of time putting together, and it's really impressive, the amount of data. So we appreciate you plugging that for her. So anyone who has not seen the real-time 911 dashboard in the chat for the meeting, there is a link to that that shows the actual chat and the link there. We also have the link to the Stop the Falls organization website as well. So great presentation. Any questions for Melissa?
All right, well, thank you for having me. I will go ahead and post the link to the 911 dashboard in the chat box for anybody, as well as my Banner Health email. So if any of you want to reach out or have any questions about our programming at BUMCP or anything to do with Falls Prevention Coalition, feel free to reach out to me. Thank you so much.
Thank you. And I do see, sorry, I missed Vicky's comment in the chat as well. Just a reminder that she mentioned about ground level falls. An isolated hip injury in Arizona is underreported in the state trauma registry data due to the fact that these do not necessarily all go into trauma centers. They would not necessarily get into our trauma database. And also different centers have different inclusion criteria and interpretation of hip injuries. So when we publicize our data with isolated hip injuries in our trauma report, that is certainly an underrepresentation because it does not demonstrate patients who go to non-trauma centers. So again, really good discussion. Certainly this affects the trauma community quite a bit, as well as our EMS providers. If there's no further question, I apologize. My printed agenda was different than the one that's presented here. So we will go back to the EMS annual report. If we can go ahead and pull that up, please. So Vatsal has asked if I could share this today. So I just wanted to go through, we will not go through the whole report. This is still in its draft version. We should hopefully have this final version publicized here in the next few weeks, and we'll share that with the committee as well. If we can go ahead and scroll down just a little bit, please. The snapshot. Excellent. All right. So this is our snapshot for the 2021 data. So just as a reminder, when we do this data, it is linking to some of the hospital discharge data. So that's why it takes a little bit to get that final report in. So this is 2021 data that is now being publicized in the 2022 report. So if you look at the EMS incidents for that year, you can see we had over 1 million, so 1,231,000 incidents, and just over 1 million were included in the analysis for the report. We have a list of our active EMCT certifications at the top right, including new applications that we received, and a list of our EMS agencies. So a total of 179 EMS agencies that submit data to AZ peers. When we evaluate the number of calls per day, you can see a large number of EMS calls throughout the state of Arizona on a daily basis, over 3,000 calls. And those numbers have gone up in 2022. We're seeing not only an increase in population, but also an increase in 911 utilization. So we do know that those numbers have been increasing. If we can scroll down just a little bit further, we did add in this EMS annual report a request from the committees last time was to have a kind of a pediatric specific section on here. So we have prevalence of primary and secondary impression categories of interest on pediatric patients. You can see injury, 19%. Respiratory distress, 8.6%, seizures, psychiatric disorders, suicide attempt or thoughts, and then substance abuse. So we do get quite a few questions regarding what is the frequency of these type of calls in pediatric patients, and wanted to make sure we included that in the data as well. The map on the right, you can see county-specific EMS incident rates for 100,000 Arizona residents. And so you can see there are certainly, there's some counties that have a much higher rate based on their population of 911 calls. Certainly the western region with La Paz County appears to have the highest percent at this time. We have the median time intervals for 911 ground, EMS ground incidents. So you have the response times, scene time, and transport time. Again, this is across the whole state of Arizona, so we know that there's a wide variation based on geography and jurisdiction sizes as well. The next section at the bottom, prevalence of primary and secondary impression categories of interest. You can see here, injury is 14.5%, substance abuse 3.7%, psychiatric disorders 3.4%, seizures 2.1%, and cardiac arrest 1.7%. So interesting when you look at the kind of general prevalence versus just pediatric seizures, it's certainly a higher percentage in the pediatric patient population. And then mortality by primary and secondary impression categories. Again, we have kind of our big categories we would expect, such as cardiac arrest, which is just under 86% mortality rate. Opioid overdoses or presumed opioid overdoses about 13%. STEMI around 8%. Stroke 5.5%. And then diabetes 2.5%. So interesting as we kind of look at the overall snapshot for this data. I think this will be shared with the whole committee once we do have the final report here in the next couple of weeks, but wanted to give just a quick preview of the snapshot data. Any question about any of those items? So one thing we did want to mention is this staff annual report is statutorily required, and we will continue that. We are considering with the EMS annual report, as Vatsal has built out these real-time live dashboards, where you have 911 data that's actually real-time within a week of the call volume, and we have Tableau dashboards, which you can kind of go into yourself, filter by county, by any number of different variables. That we'd like to transition to that part as opposed to our EMS annual report, recognizing that it takes quite some time to put together a written report. We don't know how many people actually go to the written report, but we do recognize people are starting to get more traffic to our real-time data and our Tableau dashboard. So wanted to put that out there as kind of a preview. Questions?
Hi, Iman, neurosurgery. We had in a 2020 report a surprising increase in mortality of GCS's 8 or less, severe head injury. Usually it was less than 40, between 35 to 40, and that year, 2020, was 45%. I was just wondering what it is for 2021.
And was that the trauma report or the EMS annual report?
Oh, trauma report.
I think that was the trauma report.
Okay, sorry.
No, that's good.
I missed last one, the last step. You probably reviewed it at that.
Yes.
All right.
So, but we can definitely, some mortality rates, GCS, less than 8, okay, 2020 versus 2021. Okay. I know that, Bob, I'm sure has that data for our trauma report.
Okay, thanks.
Yes, absolutely. Any thoughts or comments? I think Melissa did an awesome job of publicizing the 911 dashboard. We were going to bring that up, but she went to that and showed everyone real time what that data looks like. I think as you start looking at different grant applications for your entities, different opportunities to kind of look at data, we have so much data that Bob and her team have produced that is on our website. If you have any questions trying to find that, I know our website sometimes you have to go digging to find where that is. Please let us know. You can reach out to any of us and we can help you find where that data is on our website. But there is just, with the volume of EMS reports that we get in, combined with the linkage with the hospital discharge database and ASTR, we really have a mountain of data that we can utilize. So wanted to make sure we shared that with everyone. Any questions at all regarding EMS annual report before we move on? I don't see any online either. We will go to our standing committee reports. First up, Sean, are you in the line for our TEPI report?
I am. Can you hear me?
We can, thank you.
Okay. So we met on July 21st and we had our motion to approve minutes seconded and approved. We discussed an ad hoc report that Bossel worked really hard on at the request of some of the members of the committee, Vicki, myself, a couple other people, regarding ground level fall hip fractures. As Vicki noted, and as Melissa has noted, the report for ground level fall hip fractures via the trauma registry is grossly underreported. So Botsell went and looked at the hospital discharge database and presented the data to TEPI. We had 7 tables of data on the frequency and percentage of trauma and combined hip fractures from 2019 to 2021. The hospital discharge database for trauma centers reflected 18,413 cases. The discharge database for non-trauma centers reflected 217,909 cases. So you can see what we're reporting in the trauma registry is a drop in the bucket for ground level fall hip fractures. So I really appreciate Melissa and Vicki and Botsell helping us bring this gross underreporting to light. We also discussed the data dashboard, the 911 dashboard. I'm not going to belabor that topic. We discussed projects to pursue with trauma data. And we also noted there's some limitations to the overdose data because of not all agencies collect the secondary impression in their patient charts. We discussed the share. We actually had a presentation. Bruce Barnhart did a presentation on the share data, and we noted some outcomes improvements, and he thanked hospitals and EMS agencies for their participation and for their help with improving these cardiac arrest outcomes. We also discussed trauma registry needs and any considerations that we had. One of them was the patient ID number crossing over and duplicating when submitted. So Carissa Wilson is going to take that to ESO and see if we can resolve that issue. We then adjourned the meeting. And that ends my TEPI report. Thank you very much.
All right, thank you, Sean. Next, Sandy for Education Committee report.
Yes, thank you. We all also met. We approved our draft minutes from July the 21st, and we did Discuss and amend the approved draft training for the national guidelines for EMS field triage of injured patients. And the training was approved as it was presented. We discussed, amend, and approve the draft training for the pre-hospital death notification. The training made by Jason Johnson was seconded, and Mr. Shaw gave the background on the training development. The training was approved with edits for clarity provided by Mr. Smith. We discussed and amended the approved draft training for STR or EMT, for EMT, airway, and CPAP. Motion to approve. The training was approved with edits for clarity again. Our standing items, we review tables for training modules and approve forming work groups to update or create materials as needed. It's always an ongoing thing with education. We always have to continue to update and make sure everybody is up to date. Members discussed the list. The motion to approve forming a work group was reviewed, posted training. What should go into your EPCR? The work group was approved, and there are volunteers that have signed up for that work group. We discussed the schedule for training review and coordination with PACES. And Dr. Bradley gave a background on this topic and wants more education committee and PACES members to join each other's work groups to cut down sometimes on those lengthy delays between the meetings where training has been approved. So that was something that we felt was very important. We discussed seeking stakeholders' input on critical care certification and community paramedicine. Certification, there is a survey link. And Chief Garcia gave background on the topic and encouraged members and stakeholders to give feedback on the topic. So Chief Garcia also shared that the department is researching both routes, endorsement versus certification, and for future updates and may change the wording on the survey to reflect endorsement after certification. And following that, our meeting adjourned.
All right, thank you, Sandy. Dr. Katz for PMD update.
Thank you. So as mentioned, we met on July 21st. The critical items or the most notable items were that we added a standing agenda item to discuss medical direction topics for hospital-based paramedic practice. This last meeting didn't have any notable items to discuss, but that will be a standing item. We discussed the topic of making glutathione required instead of optional drug on Table 1 EMCT drug box. There was no motion made after some discussion. We requested a volunteer to bring forward drug profiles for ibuprofen and acetaminophen. Brian Smith volunteered to do that work. We discussed, amended, and approved a work group reviewing and potentially expanding drug table 3 special agents for eligible for administration and monitoring. There were several medications that were brought forward for paramedics to use in a hospital setting, everything from Dilaudid to propofol, several vasopressors, etc. The conclusion of that discussion was to review this entire topic after ADHS has more information, and that will be that was tabled. I brought up a discussion item to show dexamethasone or solumedrol as optional for paramedics, and that was, let me see here, that was approved. There was discussion to remove the sodium succinate modifier for methylprednisolone, and I went ahead and withdrew that item because of the approval that I just mentioned on the other steroids. I brought forth a discussion to add IO placement, intraosseous placement as an STR skill for EMTs, and that was, after discussion, I went ahead and withdrew that item. There was a discussion on options for the T3G updates, and Dr. Bradley proposed organizing basically a one-day retreat concept with all of the DMD members in order to get as much work and cohesiveness as possible, and that was approved and on schedule, I believe, for later this month, correct? And so based on that transition to a one-day retreat arrangement, we went ahead and tabled all further discussion on the other T3G sections that were on the slate for approval. And so that's it. That's all I have. Thanks.
All right, thank you very much. Next up, Kara for Trauma Managers Work Group.
Hi, good morning, everyone. Thank you for having me here to speak. So we have not met again since the last update I provided, but our upcoming meeting is next Friday, January 27th. It's going to be hosted at Banner University, Phoenix, by Brian Bates and his team. We've got a great agenda prepared for that meeting. We're going to be discussing the Bureau report that we briefly discussed today, as well as talking about geriatric care, and then providing some networking. That's been something that a lot of our trauma managers have been asking for, is increased time to network with other managers. So we're going to have some networking time, and then talk about the human trafficking that we're all experiencing as trauma centers, some injury prevention, and then TQIP takeaways, as well as falls prevention, like Melissa presented here. So we've got a great, robust meeting coming up. With that, we have built a advisory group for our trauma program manager workshop. So we do have a group of trauma managers that are now getting together to plan all of our meetings and agendas out to make sure that we're hitting all the aspects from level 1s all the way to level 4s. And we've got our meetings will probably be finalized almost through the end of the year, probably coming up in the next couple of months, so we can report back out on that.
Thank you, Kara. Next, Adam Rodriguez for our PACES update.
Hello, good morning, everybody. At our last PACES meeting, we had a few a few work groups that had some discussion. The training gap work group made edits for a training module that will appear on the Education Council's agenda for approval. That'll cover the training gap work group identified seizures as the target of this education. So Education Council will see that on their next agenda. The behavioral health work group will be sunsetted after an educational draft regarding behavioral health. And sunsetting that group is going to make way for a new work group that we voted to create. And this is in alignment with our EMSC grant goals to stand up a new EMS pediatric pre-hospital recognition program. And we are soliciting for members. So if you'd like to help, that group is going to create a recognition program for pediatrics in the EMS space. And lastly, we did elect a new vice chair. We'd like to thank Chris Ramos for accepting that position. He'll be a valuable link between Education Committee and PACES. Otherwise, that's all I have. Thank you.
Thank you very much. All right, next for our discussion action items, we can go ahead and present the meeting minutes from our last SAD meeting, September 15th, 2022. If I could get a motion to discuss, amend, and approve the meeting minutes.
This is Sean, so moved.
Thank you, Sean. Can I get a second?
This is Sandy. I'll second them.
Thank you. All right. We'll just scroll through those. They were in your package review ahead of time. Any recommended amendments? Hearing none. Anyone opposed, please say nay. Any abstentions? All those in favor say aye.
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 All right. Next up, we have Lydia on the line to discuss the new EMS Trauma Online Portal. I think Chief Garcia did mention this in her earlier report. Just a reminder, as this goes live, we will make sure that there is communication that goes out to the entire state and EMS community about this. but that was covered earlier in her presentation as well. Next, we have a discuss after presentation, altering vehicle trauma and pediatrics, the effect of legislation. So we have a presentation we will bring up here.
Hey, Jennifer, come up here, or will they be able to hear us?
You know, you're right under a microphone, right above your head, so that is actually a perfect spot, so.
You sure? I just didn't want anyone behind me to
Yes, or you can come up here, as long as you're close to a microphone, that is great.
Sure.
And then do you have a presentation that Shelley can present?
Yeah, so I have it on my laptop. Is it okay if I share?
Yes, are you logged in?
Yeah, I went ahead and
Yes,
tried to do
perfect, that will work, thank you.
So while he's pulling that up, I'll just introduce him. First of all, I'm Todd Nicholas. I'm the Director of Trauma Services, Children's Surgery and Injury Prevention at Phoenix Children's, and I'm grateful for the opportunity to share this work that iPod and I have done. He's a colleague of mine, a medical student at Creighton and a formerly research coordinator at Phoenix Children's. He presented this at the National Pediatric Trauma Society meeting in November and won the Injury Prevention Award abstract category, and so he's gonna share that presentation and what our next steps are going to be. So go ahead, iPod.
Thank you, Todd. Can everyone hear me online all right?
Yes, we can.
Yes, we can hear you.
All right, perfect. All right, well, thank you everyone for having me today. This is very exciting. Like Todd said, we had to present this at the PTS conference in Portland, and they actually had me do it in 6 minutes. So I'm able to keep this concise and informative. So the way I'll do the presentation, I'll give you guys information, and at the end, I'll invite Todd to give any final thoughts, and we'll take any questions. The reason that we were interested in this study in the first place, this is going to be a national study looking at whether laws actually have an impact on ATD injuries and fatalities, specifically among children. The reason we're interested in this is because we saw that there's a discrepancy. So if you look at all the ATV riders nationally, children make up about 14%. But when you look at injuries and fatalities, they make up 37 and 28% respectively. So it's disproportionate that children are being injured on ATVs. And so we wanted to conduct a national study to be able to look at if there's a relationship, if laws do make a difference. And so we can also further recommend what laws happen to be useful. So the first thing that we did is we conducted a literature review. So we looked and saw what are all the studies that have already been conducted and what are they saying about the role that laws have on injuries and fatalities among children. And the results were split. There's some that show that there was a benefit, and there's some that show that there was no benefit to having stricter laws. And that was something that we found interesting. It is important to note that a lot of these studies, they only looked at like one trauma center or one state. And that was something that we wanted to kind of touch on was what does it look like nationally and how do states compare? So we took the research that was done prior to us and we built on it. We saw what were the strengths, what were the disadvantages, and then we tried to take the best and use that methodology. But there was no standard methodology. So everyone was kind of doing their own thing using different databases. And so we tried to figure out what was the best approach to looking at this nationally. So first things first, we wanted to kind of highlight two specific studies that have to do with Arizona. This first one was with Peter Ree down in Tucson, UMC Tucson. They looked at about 5 years of data, and they saw that the crash rate per 10,000 vehicles was way higher than for automobiles and motorcycles. So the study is showing that ATVs pose a much, much higher risk for injuries and fatalities, especially among children. And you guys can see that on the graph there. You could add automobiles and motorcycles together, and ATVs they're far above. So that was that first study. The second one was 2017 study, looked at about 7.5 years of data instead, at PCH. And what we're seeing is that these injuries that children are coming in for, about 50% are requiring surgery. 50%. That means that we're having to use a lot of our medical resources to take care of these children and to try and save their lives as well. So it's an important area in the trauma community for us to highlight. All right, so this is a little bit more of the science. I'm not going to bore you with all the fancy statistical terms, but I kind of want to give you guys an idea of how we did this, so that way you guys can kind of appreciate the data that we found. So the first thing that we did is we did a legislative review. And I'm no lawyer, but it was rather difficult to, first of all, find this information, try to figure out what our state's saying about ATVs and what are the rules and policies that are in place. But what we did is we looked at every single state, and we looked at everything they had to say about ATVs. And then we decided to focus on 3 specific categories for further analysis. The first category being the age requirement. Second category, whether ATVs are allowed to be operated on roads. And then the third is if there is a safety requirement to be able to operate an ATV, specifically as a child. What we did with that information is we scored it. So we tried to figure out what would make a strong law and what would make a weak law. And we assigned a score to each state and added those scores up to create a composite score. That way we can kind of compare the states and see if there's going to be a pattern. And then finally, we did an analysis. So I'm not sure if you all are familiar with the Fatality Analysis Reporting System. It's a National Highway Traffic Safety Administration database. It looks at all kinds of data sources, whether it comes from EMS, it comes from police reports, it comes from hospitals that involve a fatality. And they provide about 160 variables, 160 data points. And we use that database to try to figure out how many injuries were occurring in a year, how many fatalities were occurring. And then we did a correlational analysis. So we're looking at the composite scores that we gave to the states and the patterns of injuries and fatalities to see if there is a pattern. So we kind of adjusted this slide a little bit to be more appropriate for this audience. So be kind of interactive. So these are how we scored the age requirement. So a strong law would get a score of 2. And something that would make a strong law is no child under 12 is allowed on an ATV at all. And for you to be able to drive an ATV on your own without supervision, you have to be at least 16 years old. So does anyone have any idea what Arizona scored for this category? Any guesses? 0. Yeah, 0. Yeah. So for roadway usage, this is how we scored roadway usage. So strong law is, again, a 2, and that's where ATVs are not allowed on roads, paved roads at all, public roads at all. Does anyone have any idea what Arizona scored? 0. It's 0. All right, and here's our last one, so safety education. This one's a little bit more simple, just binary. Do they have some kind of safety education program or not? Any guesses as to whether Arizona has a safety education program for kids? No, it's 0. So Arizona is kind of lacking there on laws. And so from here, we'll show you guys kind of what that meant. So here we go, composite scores down there on the x-axis, and then we're seeing the injury and fatality rate per million on the y-axis. And Arizona's right there on the left in the red, 0. You can see all the other states kind of where they sit. This is kind of just so you guys have an idea of all the states. You might be able to draw some of your own conclusions as to some patterns, but we'll talk about a few ourselves here. So again, 0 and 1 is what we categorize as weak laws, and then 2 and 3 is what we categorize as being more of a moderate law, and then 4 and 5 is strong. It should be noted that there are 17 states that ranked as having weak laws, 28 states that ranked as having moderate laws, and only 5 that had strong. And of course, it's going to be relative to one another. This is not a very objective score as to is the law strong enough, even in the strongest states. This is another way to kind of look at the data. So this is where we drew our conclusion. What we're seeing is the states that had a strong set of laws, they're the ones that saw a statistically significant reduction in injuries and fatalities among children. It wasn't enough to have one of those laws. It wasn't enough to have 2. You needed to have a good set of laws. And, you know, if I may speculate, I think that's because the idea is you have to create a safe ATV riding culture. It's not enough to kind of just have a rule here or there that people have to follow. So that's kind of what this image is meant to show. All right. So just a few limitations I think that are worth mentioning. There were several. Like I said earlier, access to legislation was a big one for us. It's kind of hard to figure out exactly what a state said about ATVs. They don't make that very accessible. But I think the biggest one is going to be that second one. So it's one thing to have a law, and it's an entirely another thing to actually enforce that law and to make sure that people are following it and people are respecting it. So there's no great measure for us to figure out if these laws are being enforced in each of these states, and that's going to make a big difference as to whether these laws are making a difference in our communities. So we're just scratching the surface. Todd and I have been working on this since 2020. I started off as just a volunteer at Phoenix Children's Hospital, and then eventually I was hired as a clinical research coordinator, and now I've moved on to medical school. So I've returned back to being a student learner and volunteer. But there's a lot that we want to do. I think the most exciting work that we're planning on doing specifically for Arizona is we're interested in doing a statewide epidemiological study. We've already submitted an IRB request with it's a state trauma registry, is that right?
Yeah, for state registry data, yeah.
We did that in August, so we're just waiting to hear back from them, and hopefully we'll be able to get access to that data so we can kind of make more robust conclusions across the state rather than what we've seen earlier with these single trauma registries. And among other things that we're interested in looking at some more laws. We're in works of doing that now, refining our scaling, doing a zip code analysis, see just kind of what the relationships exist from where people are from and where they're riding, and then the national regionality considerations. That's kind of talking about that ATV riding culture, where riding an ATV in the American Southwest is not the same as riding in the New England area. So we want to be able to like separate the two and see if there are even more patterns there. And with that, I want to invite Todd to kind of offer any final thoughts, if you have any, and we can take questions after that.
Nope, I think, again, you did a great job. We kind of, to solve this problem, we invented our own methodology, so that's a limitation that there wasn't an objective way to do this that we could diss from the literature. The ideal would be to do it like a pooled time series analysis, and there's only one person I know of that can do that, and she's otherwise indisposed. So this is what we had access to, and I think it proved some interesting results. So, open any questions or comments.
I've got a question. Fascinating stuff, very eye-opening. I wish I could say surprising, but so when you guys were auditing the other state legislative content, if you found yourself sort of in a stalemate, couldn't find it, couldn't access it, didn't know where to look, what were the steps? Did you contact boots on the ground at the state? Can you kind of paint a picture of what that's like?
Yeah, absolutely. Yeah. So the legislative review was challenging. I was the only person kind of working on that. That was back in 2020. Kept up with it as best as we could throughout the years. We did our best to go directly to the state, figure out if they had any statutes that were published publicly, or if they had any other policies that were published publicly. And then from there, if we struggled, we tried to reach out to representatives to see if we could get some help on that. The response wasn't always great. We also used secondary sources. So a lot of lawyers, they'll post blogs to kind of build a clientele and build some trust for their community. So we tried to use that to kind of corroborate the information that we're finding directly from the state. But generally, we're able to access every state's laws or statutes and have some kind of idea. Sometimes we'd see something like on a lawyer blog that we couldn't find in the statutes, and that's where we kind of had to sit down and figure out, well, what's the actual truth? How would we score that state? The three that we chose, though we didn't have trouble with those three. Those were generally discussed across every single state. They had some kind of age requirement. They had some kind of discussion about if ATVs are allowed on the road. And then what was the third? Education. Thank you, education. Those were pretty easy to find. But when we go into greater detail to look at more laws, that's where we'll probably need the help of maybe like law students who are hoping to maybe incorporate the public health students. So as we continue to expand the project, I hope that answers your question.
Yeah.
I'll make a quick comment about enforcement versus the law. You know, one of the things that we were able to gather from the simply passing the law actually increases the amount of usage by about 38%. So it's not 100% when you pass the law, it's not 0%, but basically it does have a meaningful impact, 38% more compliance if you pass the law, and that's independent of enforcement because a lot of the laws were secondary enforcement, so you had to get pulled over for some other reason before they could even enforce the law. So.
Yeah, I think, and related to that too, with ATV, it's challenging because a lot of these are done in areas where there is no one there to enforce. Another thing that we're hoping to look at in the next analysis of Arizona in particular is that we have a lot of public land where a legislative, like a law like that would be in effect. But we also have a lot of private land where a law would not make a difference for that group. And we want to see if, the injuries are occurring more often on public or private where a law that's properly enforced would potentially make a difference.
And then U of A did a study, or I think Randy Freeze did a study basically showing that there's a relationship between the power of the ATV and the injury rate. And as the power of the ATV goes up, or as you allow younger riders on more powerful ATVs, that they have worse injuries, which is an interesting finding as well.
I think there's one more question we have time for. Sandy, is that you with your hand up?
Yes, it is. I know your data specifically says ATVs, but are you also looking at that category known as dirt bikes, which are motorcycles, but they're sort of a separate category? Because we see a lot of kids riding those too.
Yes, that's a great question. So we did not include dirt bikes in the analysis. In fact, we're pretty specific that even what constitutes an ATV was well defined. So across the states, in the United States, they generally define an ATV as being a vehicle that has 3 or more wheels. Some say 3, 4, or 6 wheels. Apparently there's 6-wheel ATVs out there as well. And they have to have a straddle seat and handlebars for steering and low pressure tires. So that would be the definition of
no
an
cage.
ATV. What's that?
And no cage.
No cage.
No cage.
Oh, no cage.
Yeah.
No cage. Yeah, sorry. No cage. The only things that would differ in definitions had to do with the size of an ATV's engine, for example, and maybe some of the more like equipment type modifications. So those are the only differences in definitions. But in general, we definitely didn't include anything like side-by-side, golf carts, dirt bikes, nothing like that. We're very specific about what we define as an ATV.
Thank you very much.
Yeah.
That was an excellent presentation. We
Thank
appreciate you coming today. We definitely would like more presentations up like this as part of staff. So if anyone has any future presentations, please reach out to either myself or Shelley Bissell. Shelley's email address is in the chat box as well. Next, standing item, Dr. Patel, are you still on the line for the ACS Committee of Trauma report?
Hey, good morning, folks. Real quick update on a couple of things. One is verification, the other is education. From a verification perspective, break it down into 3 sections. It's the optimal resource document, verification visits, and the virtual versus on-site and the level 4 process. For the optimal resource document, as you're all aware, right, and it's available online on the webpage, the new standards were released in March of 2022. And as you're all aware, as was done in the past with the electronic revisions or updates, the same process continues for the new document. And the most recent one was just posted for December of 2022. So for all of you who are looking at the new standards and those who have visits coming up in the latter part of the year, and even those who are now looking at their programs as they prepare for their future visits, please make sure you're keeping a tab on the revisions that are being put out, right? So you're not just following the original document. For verification visits, for re-verification visits, they will all stay virtual for 2023, and there will be no on-sites. Regarding the new standards, the consultative visits that will start now soon will be on the new standards. For verification, they will kick in September of 2023. And for the focus visits, those standards will hold over until September of 2024. So those who have focus visits coming up, before September of 2024, those will still follow the current standards and not the new ones. From a on-site visit perspective, that is being considered now for the consultative and the new verification visits. And part of that is it's really felt that there is value, especially for new programs and consultative programs, to really be able to have a face-to-face sit down. So the on-site visits will most likely come into play for consultation and new verification. For level 4 standards, as you're well aware, right, the 2014 resource document are the most current standards that are out there. They're still in use. The revision process is ongoing, and it's being done through a feedback survey that is being shared. I'll make sure I send that link to Shelley. Please offer feedback to the VRC as we start looking at revising the level 4 standards for the new document. So that is an opportunity for our partners to be able to participate in the state and give the college feedback. Any questions regarding verification before I move to education, or would you like me to finish education and then stop?
Any questions for Dr. Patel? I think you continue. Thank you.
And just two very quick things for education. ATL as well. Let me back up one. As you all know, the hybrid options are being explored and have been executed in multiple programs from the COT, and those will continue. ATLS, the 11th edition, has now already started. The work has started. It is going to be a significant change from the 10th edition. And I think it's going to be a very promising change with the way that it's being looked at. And it's also now starting to take a more international focus, a global focus, than just a US-centric. And I believe the anticipated launch for that will be in 2024. But that work has already started and in progress. RTTDC, we will be meeting in March we've been asked to look at creating a hybrid option for RTTDC or a virtual option. And so that is being explored to see how we could do that. And then from a perspective of the BEST, the ADAM, asset team courses, DMAP, a lot of those have already been revised and the new courses are already up and running. The others are all in the process of final revision. So we should be basically have all the updated versions in 2023. And that's the update from the ACS. Thanks very much, folks.
All right, thank you very much. I think we can actually skip item E, because Dr. Patel did cover that quite well during his presentation. I'm going to use the chair's discretion and skip to G, because I want to make sure we cover that, as that's a pretty big project that did go live. If we can click on that link on the agenda, please. So for those of you who have been on staff for quite some time, the last field triage update from ACS that came out in 2011, staff had endorsed at that time. And so this update that came out from ACS in 2022 was really the first one in over a decade and had some substantial changes. And so we recognized there was a need to put together some education for EMS and how to implement these new guidelines. The education committee got together and did put this PowerPoint together. We have it in a number of different formats. So a big thank you to Drs. Munn and Dr. Rice from University of Arizona. They have created a format that has got kind of embedded audio, and this can be uploaded directly to your learning management system. You do have the option that you can just download the PowerPoint or PDF and then kind of do your own education. But for anyone who is interested, we wanted to make sure that we really spent some time going through this. So this is the PDF version that is being shown right now. You can see, you can keep scrolling there. We really wanted to spend some time talking about what the new guideline looks like, how it's supposed to be read and implemented. We can kind of keep scrolling. It talks about, you know, the flow of information, really completely different format compared to our old version, and then highlighting some specific changes that came into play, very specific items for both pediatric patients and the geriatric patient population. Keep scrolling there. So we've got the high-risk serious injury, and then we go into each section, talk about things that are being clarified or reworded. So as you go through the presentation, it does kind of really highlight things that are different or changed. Some clarification pieces like this one where you see the green arrow clarifying regarding tourniquet or wound packing, completely new to EMS scope of practice compared to 2011 when the last update went live. Next, for clarification, there were things added to some clarifications under the injury patterns as well. And then the mental status and vital signs, this is probably the area that had the most changes, where we really have some very specific findings related to a GCS difference. So this is looking at having EMS no longer calculating a complete GCS, but really focusing on the motor score specifically and recognizing that it's going to be much more accurate. There was great data to support this change. I think this will be easier. The one struggle will be that most PCR systems and EMS agencies still use require the full GCS score. And I think BEMSTS, which is the National EMS database, they are looking to update their kind of every few year update was going live this year, kind of crossed over a little bit with ACS finalizing that, but they are working closely with ACS to find a way to kind of merge those two things. But I think this will be something that will be a big change for EMS, but will be quite helpful for them moving forward. So there is some education as well about a pediatric motor score. Again, the pediatric-specific vital signs, geriatric-specific vital signs. You can see here as we scroll down to this is kind of a modified shock index for EMS, and this is something that we also knew that is going to be added to the guidelines as well. So we wanted to make sure there was some education that was added. So the audio version that can be updated does go into a little bit more detail, so that's why I'm trying to plug that version, because I do think it will be very easy for agencies to implement that version of it. Some additional findings there. Sorry, if you can scroll back up just slightly. Another substantial change under the addition/modifications. Sorry, a little bit slower. Oh, Shelley's doing it. Oh, back up, Shelley. I know we're doing this virtually. There we go. All right, so we've got changes with very specifically added. So children 0 to 9, unrestrained or unsecured child safety seat. So that's a pretty substantial thing we know that's associated with injury in children. So that is an addition that ACS did add in. Next slide. We also had a big change, which is that now all falls greater than 10 feet for all ages. So I think historically most people remember it used to be greater than 20 feet for adults or 3 or more times the height of the child for pediatric patients. But again, if you think about a fall of 12, 15, 18 feet, it's pretty substantial. And so that 20 foot was found to be probably a too high cutoff criteria. And next slide. This is the part that will probably need some education as well. This is considered EMS judgment, and the training PowerPoint really does go into this quite a bit of depth. Someone at 520 number, if you can mute yourself, thank you. So really there's a few things that were added here. So we did have a clarification from ACS about low-level falls in young children, less than 5, or older adults greater than 65 with significant head impacts. And the other change was anticoagulation use is called out separately, so it's no longer linked specifically to head injury. One of the key pieces with this is, again, this is your EMS judgment section. So this is really looking at the clinical presentation. So as you go further down in the presentation, we have specific examples that are used to kind of demonstrate how would you actually implement this. This is not saying that every ground level fall on anticoagulation needs to go to a trauma center, but recognizing that EMS needs to look at the clinical presentation. Does the patient have an altered GCS? So are they confused? Do they have a laceration with a large blood loss unseen? Do they have a secondary injury on top of their head injury? So they've got a wrist or ankle fracture or a hip fracture on top of a head injury. And so we did include quite a bit of examples with this. So in the interest of time, I won't go through all of this, but like I said, we've tried to make this available. And a big thank you to Drs. Rice and Munn for putting all the work in creating this training. So we will make sure that this goes out to everyone, but STAB is really obviously the governing body of the trauma system in Arizona, so we wanted to make sure that this group did see this presentation.
I'm just curious, Dr. Bradley, how deep of a dive do you guys take on the shock index?
I remember it's been a while since I watched the actual thing. It's a decent amount. I think it's enough for people to understand it. So not super deep, but I think enough for the EMS local provider. Any other questions? All right, in the interest of time here, I'm going to ask if we can potentially table items F and I I need a motion to table those items.
Motion.
Thank you. Can I get a second? I got a second for that.
Second.
All right. Thank you. And then just quickly, I don't know if Chief Garcia, if you wanted to just mention the regional EMS and trauma needs assessment.
Yes, good to see you guys again. I'm sorry I had to step out for a moment, but it's awesome to hear how much progress and everything that was covered today. In closing, I guess our last agenda item before Dr. Bradley takes it back is we have our trauma needs assessment. It's an EMS and trauma needs assessment that we hope to get out through each regional council at the end of this month. We will keep that survey link open for at least a couple weeks or as long as it takes to really get adequate feedback from the trauma and EMS community. We want to encourage everyone to really take a good look at that survey and give us your feedback. The information that we collect through that needs assessment will be used to help inform the state EMS and trauma strategic plan and potentially future funding requests. So we really appreciate everyone staying tuned and really giving us your feedback through that survey. We can't do this without all of you. So thank you in advance. And I don't know if Julia wants to plug anything else or if I'll hand it back to Dr. Bradley.
All right, thank you. If you have any agenda items you'd like to be considered for the next meeting, please let either myself or Shelley Bissell know. We have a call to the public. Anyone online or in the room?
So for those that need additional pediatric trauma education, the Western Pediatric Trauma Conference will be in July in North County, San Diego, Carlsbad.
All right, thank you. All right. We also do have a list of upcoming events on your agenda as well. Our next meeting will be May 18th at 9 a.m. And if I can get a motion to adjourn, please.
Motion.
All right, can I get a second?
Second.
All right, thank you. Meeting is adjourned. Big thank you to everyone.
Yeah.